not held a transducer right from the beginning to take their expertise and capacity building up to the basic level is not a joke. So that is what Preeti will do for us. So Preeti, you can start. If Ashmukh sir, you want to tell anything about her, you may.
Preeti has been the first fetal medicine specialist of our state, and she is mainly responsible for all the educational activities. We even had one very big event on cardiac meeting, and I think Ashok sir was there, and many other delegates, were there, and we had a very Ramurthy sir was also there, and we had a great time. And everybody knows Preeti for her devotion and her work, and she has her clinic in Acharya Vihar in Bhubaneswar near Sai Temple, and she is a senior consultant. And as Madam has already described her devotion, and I hope that Preeti does not need any more introduction, because everybody must have seen her during those educational events. She held so many every year. There was one big one, and some smaller ones were always there. And she has been helping a lot of people like us, in solving the mysteries and our problems. She has been always sorting it out. So thank you, Preeti, and I wish that you take us through this complex topic in a simplified way.
I'm really thankful to you all. I'm sort of words how I can thank you. You all are my teachers, and I just tear roll down from my eye. I'm just doing pranam to all of you. Thank you so much, sir. So to start with,
love you, Preeti.
Love you, madam. I need your blessings, madam. You people are so good. I'm so thankful to you, madam. I'm really thankful to you all. I don't deserve so many things, madam. You people blessings are more than enough.
We are always with you, and our blessings are always with you. It will remain forever.
God's blessings are with you. God's blessings.
So
okay,
today I am going to tell you about ISWOG basic training on heart evaluation. So I'm not going to discuss any complex things here. Just in the periphery, what are the things, basic things we need to see? That I will tell you. Only the basic things. It is a very basic slide of ISWOG. Don't think it is any complex structure I am going to describe. Just listen carefully, follow the steps, and then go ahead. It is very basic, and every person can do it. Just hold the probe and try to do. Any problem if you are facing, you can always discuss with all of us. We are there, always there to help you out. So please start seeing your heart, because the heart is the most common disease. Congenital heart disease is the leading cause of infant mortality. It is estimated that 4 to 13 per 1,000 live births. WHO has recorded between 2050 to 2045, nearly 42% of the deaths are due to congenital heart disease. So before going through this, please log on to ISWOG practice guideline updated 2013. This new ISWOG recommendation has added outflow track besides the 3 vessel view and the 4 chamber. So you go through these guidelines and then you can proceed. So at the end of my session, what we will know how to take the cardiac status. We will know what are the 4 planes in 20 plus 2 planes that is required to assess the heart correctly, and recognizes the difference pattern between the normal and the most common abnormal cardiac ultrasound. So these are the 4 planes, the 7, 8, 9, 10. I will discuss one by one again. So when we come to the 20 plus 2 planes, there are planes 7, 8, 9 and 10 which are dedicated for cardiac examination. The plane 7 which include the basic normal 4-chamber view of heart, the plane 8, the left ventricular outflow tract, the plane 9, right ventricular outflow tract, and the crossing over of LVOT, and the 10th is the 3-vessel trachea view of the heart. So in short, if you go through these images means when you sweep from the abdomen little bit up, you will get all the planes. Okay, so there are 4 transverse planes, that is abdominal situs, 4-chamber view, 3-vessel view and 3-vessel trachea view. These are 4 transversely you can get. By little angulation of the 4-chamber view towards the fetal right shoulder, you will get LVOT view. And perpendicular to it, if you will rotate the probe to 90 degree, you will get that RVOT plane crossing over the RVOT. So like that you will get all the plane, 4 by means of transverse plane and 2 by little movement of your axial plane. So all the total you will get 6 planes and you will completely rule out all major and minor anomalies of the heart. Before going to the examination, when we have to assess the heart, it is between 18 to 22 weeks menstrual age. That is by ISUHU guideline. So we will prefer to do between 20 to 22 because all the cardiac structures are well seen after 20 weeks. So anyway, as the PCPNDT has extended the termination of pregnancy till 24 weeks, we will take little bit of advantage and we can do 20 to 22 weeks for fetal echocardiography. There are a lot of things to do fetal cardiography, but one thing that is basic is what is needed. We have to see the apical heart. That is very important. You never can see the basal heart or lateral heart or manage something because if the heart is not in position, please don't see the patient. Ask her to go out, take some break and then recall her back. You may get different situation if baby is not in position, if the mother is very obese, if the mother is incooperating. So beside that, don't make these excuses and keep a look on your heart because that is the most common cause of infant mortality. So besides those things, what we need to remember are some technical factors. So we need to use a high frequency probes. That is a curvilinear high frequency probes has to be used. We have to keep our frame rates high with increased contrast and high resolution. What is more important? Because these things we know, these things are there in our cardiac presets also. But what is more important in your hand is zoom the image and use cine loop. That is the 2 most important thing that we do in our day-to-day practice. So always zoom the image. You see, this is a ESWOG picture. These 5 are the ESWOG picture. Can you see how they have zoomed the image? They have zoomed the image that only thorax is seen. The heart and the lungs are seen. Other than that, we cannot see anything. So like that, you use the zoom box to zoom your image, to zoom your heart so that you cannot see any other structure like how Arjuna has put targeted the bird. So like that you have to be. So zoom your image, cine loop, use the ball, that roller ball is for cine loop, whatever you have said, because all the cross sections will come within 1 to 2 millimeter. So if you use the cine loop, you will get all the views in one loop only. So please use the cine loop. And this is the table which is given in the ISUHU guideline, which shows how sequentially we see the fetus. Like we see the situs first, and then we go to four-chamber heart. From the four-chamber heart, how we see the atria, ventricles, everything. I will go step by step. So this is the only system. When we start with our heart, we don't actually start with our heart. We start it with the abdominal circumference. So what is the first structures you need to see when you see a fetal echocardiography? Your answer should not be heart. It should be your abdomen. How important is the abdomen? I will tell you. So this is a cut section of the abdomen. You see how they have zoomed the image. Except abdomen, we cannot see any other structure. So like that, you have to use your zoom box and you have to zoom your image. If you zoom your image, your things will be crystal clear. So this is the spine. This is the 3 dots of the spine that is labeled as SP. And this baby is in cephalic presentation. So how I will say this baby is in cephalic presentation? I will tell you, this is the stomach. This is the portal vein. This is the gallbladder. There are 2 vessels we can see. One is aorta, which is just near to the spine and more towards left. And the other is diagonally opposite. We can see inferior vena cava on the right side. So 2 vessels you need to see. They should not be near to each other, but they should be diagonally opposite to each other with a distance of minimum 2 to 3 millimeters. So that you need to remember. So what are the things we need to see? We need to see the spine, the aorta, the stomach, the portal vein, the gallbladder, and the IVC. So these are the structures we need to see. And what we must see, that at least one of the ribs should be visible to get an ideal abdominal circumference. So if we divide this into 2 equal halves by drawing a line from the spine to the portal vein, you will get a left half and a right half. So in the left half, what is there is the descending aorta and the stomach. That is very, very important structure. Descending aorta and the stomach are always there on the left side of the baby. And what is there on the right is the inferior vena cava and the gallbladder. So it is very clear that we need to see stomach on the left side. If you come to the mid-trimester anomaly scan of the SFM guideline, our own Society of Fetal Medicine guideline, we have discussed how you can assess the situs of the baby very beautifully, because it is not very clear in ISUG guideline. So you go through the SFM guidelines for mid-trimester scan and you go through the how we can assess the heart. In that guideline, it is very beautifully given how you can assess the heart. Especially they have given in a situs in a very beautiful manner. They have given, you try to keep the abdomen and the heart as a dual picture in one photo, and you see the spine, stomach and portal vein, and the spine and heart should go in a clockwise fashion. If it goes in clockwise fashion, then the head is down. That means there is cephalic presentation. And just opposite the vice versa. If the spine, stomach and portal vein is going in anti-clockwise manner, then the baby is in breech position. So without seeing the baby, you can discuss whether the baby is cephalic or the baby is breech. So what you have to do? You have to see the spine, stomach, portal vein in a clockwise manner, and then here you have to say spine and heart. They are in the clockwise manner. If that is completely right and your head is down, that means the presentation is cephalic and your abdominal situs as well as cardiac situs is normal. And that is normal cardiac situs and the abdominal situs is known as situs solitus. Sometimes we find that spine, stomach and portal vein and the spine and the heart is in opposite direction, then we called it as situs inversus totalis. So in situs inversus totalis, the heart as well as the stomach has inverted down. So that is an abnormal condition. The third condition is situs ambiguous, where one of the heart or the stomach is in position and the other is in different position. Suppose heart is on the mother's right and the stomach is normal in the left position. Other than anything which falls other than situs solitus or situs inversus totalis, we called it as situs ambiguous. So this is a small video. This is the stomach. So this is a baby with cephalic presentation. This is the spine of the baby, this is the stomach of the baby, and this is the portal vein. So they are going in a clockwise fashion. So when we will start this video, yeah, when we will start this video, you can see, is it visible? Yeah, from the stomach, this apex is always there on the left of the stomach. Okay, so both the stomach as well as apex, cardiac apex is on the left, and the fetus is in cephalic presentation, and it fulfills the criteria of spine, stomach, portal vein going clockwise direction, and the condition is situs solitus. So next is plane 8, that is left ventricular outflow tract. So this is the left ventricular outflow tract. What we are seeing next is plane 9, that is right ventricular outflow tract. So whenever right ventricular outflow tract is coming, this is the pulmonary valve. So when the pulmonary, this is right ventricle, this is the pulmonary valve, this is the main pulmonary artery, which is again dividing into left and right pulmonary artery. So the artery which is encircling the aorta, this is the aorta. As I have shown you, suppose this is the left ventricular outflow tract which goes to the fetal right shoulder, and this is the right ventricular outflow tract which goes encircling the stomach, encircling the aorta. So you have to remember this sign. So this RPA encircles the aorta and this LPA continues as ductal arch. So this is the LPA goes and drains into the descending aorta after forming the ductal arch. This is the arch view or the three vessel trachea view. We get it as a dash dot view, and here you can see the trachea. This is the ductal arch going to the descending aorta. This is the aortic arch, and this is the superior vena cava. This plane we call it as pass view. Pulmonary artery, aorta, and the superior vena cava. Remember, in this view, we cannot see IVC. Inferior vena cava cannot be seen. So coming in details about the four-chamber view. What are the things we need to see in the four-chamber view? Before seeing the four-chamber view, we have confirmed the fetal laterality. That means we have confirmed the situs, the stomach and heart are there on the left side. The heart occupies 1/3 of the chest. So this is the cross section of the heart, which heart occupies 1/3 of the chest, and each lung occupy 1/3 each. So the three things that require 1/3, 1/3 and 1/3. So majority, if we cut this into half, the majority, that is 2/3 of the heart remains on the left side and 1/3 of the heart remains on the right side. So you can see when we cut it from the spine to the sternum, we cut it in the two equal halves. We find that 2/3 or majority of heart remains on the left side and 1/3 of the heart remains on the right side. So this is the plane where we calculate the cardiac axis. So how to determine the cardiac axis? What you have to do? First, you have to draw a line from the side, from the spine to the sternum, and draw another line from the interventricular septum. Wherever that they meet, they form an angle, and that is known as cardiac axis. The normal cardiac axis is 45 degree plus or minus 20 degree. So the maximum can be 65 degree or minimum can be 20 to 25 degree. Anything more than 65 degree can point out as outflow tract anomalies or phonotruncal anomalies. Anything less than 20 or 25 can lead to mesocardia of the heart. That means the apex of the heart will come near to the midline. That could be, if it is isolated, that could be a normal finding, and it is also associated with phonotruncal anomaly. So normally we don't measure the cardiac axis. It is just our eye observation. If it is normal, you will able to find after doing 10, 15 normal heart, you will able to know that this is the normal axis. I need not measure. So that's what I am telling you. Every day you practice, only practice, 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 and you will able to do it very easily. Wherever you are, whatever you do, if you practice well, you will easily do. So the cardiac axis, anything more than 65, anything less than 25, both are abnormal and both can lead to phonotruncal anomaly. So whenever you are seeing a heart and you are finding that axis is either increased or decreased, please be careful in doing your outflow. That means you may face a problem in the outflow tract anomalies. So coming to the 4-chamber view. 4-chamber view is if you see only the 4-chamber view, you can identify more than 40 to 50% of the anomalies. Can you believe that? Only one chamber, only one plane 7, if you see it correctly, you can identify almost 40 to 50% of the major cardiac anomaly. What are those anomalies? I will tell you now. So first thing is cardiac axis that I have already described, that you have to take one line from the spine to the sternum. The other line should come through the interventricular septum, that is IVS, and the angle which is formed is known as cardiac angle or the cardiac axis. Normal is 45 degree plus minus 20 degree. Anything more than 65, anything less than 20 should point out phonotruncal anomalies or outflow tract anomalies. So be careful, keep your eye vigilant on the axis. Next is cardiothoracic ratio. That also we normally don't measure, and it is just our eye when it says that there is gross cardiomegaly, and yes, we need to see and we need to measure the cardiac circumference and the thoracic circumference. So what we do, we measure the cardiac circumference, we take the thoracic circumference, and we take the ratio to rule out if there is associated cardiomegaly. So what are the common things if you find that there is a cardiomegaly? So what next? What next will come to your mind? That first and foremost thing we need to see for some type of obstruction in the heart. That means there is some aortic obstruction, so which is preventing the heart, something which is the blood is not coming out of the heart and it is accumulating in the heart and giving rise a cardiomegaly. So first thing you have to rule out is congenital heart disease. The second thing you have to rule out is fetal anemia. We know for Rh negative pregnancy, lot of time we get fetal anemia. Even if there are so many conditions we get, with cytomegalovirus, most common is parvovirus, B19 virus, and the toxoplasmosis also can cause fetal anemia. So first thing, if you are seeing a cardiomegaly, first thing what you have to rule out, you have to rule out the congenital heart disease, see the outflow tract, if there is aortic stenosis, if there is aortic atresia, that's why the heart is getting enlarged. Second thing you rule out is fetal anemia. And the third thing what you have to rule out is anything which causes high output cardiac failure. Like if any extra thing is there, like if there is pulmonary sequestration, if there is sacrococcygeal teratoma, if there is vein of Galen aneurysm, these all causes high output cardiac failure. So in those cases also we can get cardiomegaly. So from the axis we go to cardiomegaly, and in the cardiomegaly we have ruled out these three things. If associated any cardiac diseases are there, if any fetal anemia is there, if associated any other thing which increases the cardiac output is there or not. Next comes the two atria. We know there are two atria, the left atria and the right atria. How to decide which is which atria? The atria which is closer to the spine and more towards left is known as left atria. The left atria is a horned atria. Why horned atria? Can you see the horn? These are the two horns, that is pulmonary veins, which is draining from both the lungs to the right atria. So these are the pulmonary veins which collect blood from the right and left lung, and they are draining into the left atria. The pulmonary veins are four in number, two superior pulmonary veins and two inferior pulmonary veins. But when you scan, at least two inferior pulmonary veins should be seen in the four-chamber view. So that's why the left atria is known as horned atria, because it has two horns. So just remember, you need to see these two horns are the two inferior pulmonary veins which are draining into the left atrium. In comparison to right atrium, they are the smooth atrium. They are bald atrium. They don't have anything. If we know this is the left atrium, by exclusion, the other atrium is a right atrium. Okay, so next is the atrioventricular valves. We know there are two atrioventricular valves. One is left atrioventricular valve, that is known as mitral valve, and that is a bicuspid valve. In contrast to the right-sided atrioventricular valve, which is a tricuspid valve. Okay, so we have two valves, mitral valve on the left side, which is a bicuspid valve, and a tricuspid valve on the right side. The movement of the atrioventricular valve to and fro need to be seen in the four-chamber view. Next comes the ventricles. We have two ventricles, the left ventricle and the right ventricle. So like how we have described this left atrium as having horned atrium and having so many features, like that left ventricle is a bald ventricle, just in contrary to left atrium. It doesn't have anything, and it is a very smooth ventricle in contrast to the right ventricle. What is there in the right ventricle? A thick band of tissue at the end, that is known as moderator band. The insertion of the atrioventricular valve of the right side is placed apically close to the apex of the heart. Can you see? This is the apex of the heart. So which valve is inserted first? This is the right ventricular valve which is inserted first. That is the tricuspid valve. So apical insertion of the tricuspid valve is the marker for right ventricle. So what we are getting in the right ventricle? We are getting a apical insertion of the tricuspid valve and the moderator band. So this marks the right ventricle. And what next is the crux of the heart. What is the crux of the heart? This is the
Preeti got disconnected or what?
Not audible.
Hello, Preeti.
No,
You're not
I
audible.
think
Are
she
you
lost
muted?
connection.
Oh, we can see her slide. Hello, Preeti.
So,
So give her a ring.
hmm.
Can I start? I think
Yeah, please.
it is
Yeah.
visible, na?
You were at the crux of the heart.
Yeah.
You were telling about the crux of the heart. Yes.
So these four things makes the crux of the heart. If the crux is missing, then we know that there is AVSD, that is atrioventricular septal defect. Why? Because this is the septum primum of the interatrial septum, and this is the perimembranous part of the interventricular septum, and if these two are missing along with the insertion of the atrioventricular valve, that is mitral valve on the left side and the tricuspid valve on the right side, we called it as AVSD, that is atrioventricular septal defect. This is common term. With that same term, it has been applied to endocardial Cusson defect, that is commonly seen in babies with Down syndrome. So if there is AVSD, you can keep a record of this, because that is the thing which is very important to say for the genetic abnormality. Next in the line is
Preeti, you tell about the crux once more, right? What is crux? Tell once more, because some of our participants are requested to know about the crux. What is crux?
Crux and the offset of the crux. The level of the offset pattern of the normal crux.
Oh, yes. So what happens? We have two valves. One on the left side, that is mitral valve, that is the bicuspid valve, and the other valve is on the right side, that is right atrioventricular valve or tricuspid valve. So when I told you, when they are inserting at a certain distance, that is around 4 to 7 millimeter. The tricuspid valve are getting attached more towards the apex rather than the mitral valve. So this tricuspid valve is apically placed, and this difference is known as offset. Okay, and the crux involves all these four things, that is the perimembranous part of the interventricular septum, the tricuspid valve, the bicuspid valve, and the septum primum. These four together, they form the crux of the heart. And the difference between the apical placement of the tricuspid valve and the mitral valve is known as offset. Do you understand? When this apical insertion, is it clear now? Because if the offset is increased, that means when it is more apical place, then we get the abstinence anomaly, and in corrected TGA we get reversed offset, because in corrected TGA the right ventricle becomes left ventricle and the left ventricle becomes right ventricle. So we get reversed offset in corrected TGA, whereas we get increased offset. Whenever you see there is an increased offset, that is the difference between the insertion of the mitral valve to the insertion of the tricuspid valve is increased. That means there is abstinence anomaly. Is it clear? Offset and crux.
Yes, quite clear. Susrita is very happy.
Okay, thank you. So next stage. Okay, next we will go to interventricular septum. Interventricular septum divides the left ventricle, separates the left ventricle and the right ventricle into two equal halves. When you see interventricular septum, it should be clearly seen from the apex till the crux of the heart. So when you see a clear line without any breakage, you know there is no ventricular septal defect. The upper 1/3 is membranous and the lower 2/3 is muscular part. So any defect in this is accordingly we can tell as a perimembranous VSD or muscular VSD. So ventricular septal defect can be identified in this plane if sometimes due to parallel ultrasound beam and the 4-chamber heart, sometimes we can see a defect which is exactly not a defect, that is an echo dropout. If you are finding any discontinuation in the interventricular septum, please see the interventricular septum in the lateral position. In the lateral position is the correct position where you can see the interventricular septum correctly, entirely. There will not be any echo dropout and everything will be crystal clear. So if you are finding any gap in the interventricular septum, please take the heart in the lateral position also. Next comes the interatrial septum. So interatrial septum is the septum which divides the left atrium and the right atrium. So it has three parts. This is septum primum, which is attached to the crux of the heart. This is septum secundum, that is attached on the upper part of the heart. And this is the gap, that is the foramen ovale. Foramen ovale is always there in baby hearts. It only fills up 3 days, that is 72 hours after delivery. Following delivery, it shuts down. So foramen ovale, with the foramen ovale, you have to keep a look on septum primum defect or the septum secundum defect. When you see the opening and closing of the foramen ovale, the flap of the foramen ovale opens into the left atrium. You can clearly see, I will show you a video. You can clearly see the opening and closing of the foramen ovale. The flap of the foramen ovale always opens in the left atrium. Next is the pulmonary veins that I have already described. There are 4 pulmonary veins, 2 superior pulmonary veins, 2 inferior pulmonary veins. These inferior pulmonary veins are always seen in the 4-chamber heart. So next is the descending aorta. So we have to see the aorta that I have shown you also in the abdomen section, that is always next to the spine and more towards the left. So descending aorta is always there, just juxtaposition to the spine and towards left. So this is a single vessel you have to see, because it is a aorta, it should be pulsating. So you can see, sometimes you can see the esophagus opening also here, but how to differentiate between esophagus and the aorta, you can see pulsating waves in the descending aorta. So you will easily know this is descending aorta and it cannot be anything. Okay, so descending aorta, sometimes esophagus can be seen here. And then we need to see area behind the heart. Why it is so important, area behind the heart? Because when you see a barred left atrium, you can see a parallel vessel that is nothing but total anomalous pulmonary venous connection. And in those cases, that area behind the heart will increase. So we need to keep a watch on the area behind the heart. If you systematically see all these structures, there is a paper you can diagnose 40 to 50% of the all anomalies that we can diagnose by 4-chamber heart. For example, we can diagnose pericardial effusion, cardiomegaly, any tumors, any hypoplastic left heart syndrome, hypoplastic right heart syndrome, single ventricle, tricuspid or mitral atresia, AVSD, ASD, DSD, abstain anomaly, and CTGA. So many things you can see by only seeing the 4-chamber view. Can you imagine? So many things you will diagnose only by seeing a 4-chamber heart correctly. So last but not the least, you should also see the extra cardiac space if there is lesion in the extra cardiac space. So coming to the 4-chamber view, I think overall we have done what we have to do. Fetal laterality, stomach and heart on the left. Heart occupies 1/3 of the chest. Rest lung occupy 1/3, 1/3. Majority of heart is in the left chest, that I have told. 2/3 is on the left side and 1/3 is on the right side. And the cardiac axis is 45 degree plus minus 20 degrees. Okay. So atrial equalness. We have to see 2 atria equal in size, 2 ventricle equal in size. Okay, and this is the 4-chamber, both the pulmonary veins draining into left atrium. This is the left atrium, this is the right atrium, this is the left ventricle. We can find the echogenic intracardiac focus in the left ventricle. Are you worried? Not worried. If there is isolated echogenic intracardiac focus in the heart, please don't worry, because it is a common finding and it happens in most of the population, especially in the Asian countries. So we need not make apprehensive to the patient, because most of the people, they come from far places to say that I am having some lesion, some radiologists, they used to measure those echogenic intracardiac lesion, and there is a lesion of 1.6 into 2.5 millimeter in the left side of the heart. That is all normal. Please take it as a point. Echogenic intracardiac focus in the left ventricle is a normal variant, and don't make the patient apprehensive. Only if it is associated with some other structures, then it has some concern, because it has a likelihood ratio also, it is 1 only. So we have described the left
tell us about
left
coronary
ventricle.
sinus. Can you tell us about coronary sinus, please? Previous slide, your previous slide.
Yeah. So
coronary
one thing we can miss is coronary sinus. Usually what happens, when you see a coronary sinus, it usually goes like this and it drains into the coronary sinus is just on the back side of the crust. So that is the most common lesion when you find that because when there is a prominent coronary sinus, especially when there is left SVC, ideally what superior vena cava we are seeing is right SVC. The left SVC, they degenerate. But in some cases of persistent left SVC, when they are draining into the coronary sinus, then there happens to be a very thick vessels. So what it does, it just overslide your septum primum and it appears as septum primum defect. So that is the most common erroneous thing we do. We see that, okay, it is a septum primum defect, but actually when we go to the 3-vessel view, we could find the left SVC on the top of the pass, and we could say, okay, this is the left SVC draining into the coronary sinus. That is the significance of the coronary sinus. Normally we cannot see. Only if there is persistent left SVC, they're draining into the coronary sinus, then we can see, as we could not find the septum primum, and we could suspect that it could be a part of ASD. But actually, when we go to the 3-vessel view, we could find an extra blood vessel there, that is persistent left SVC. And from there, persistent left SVC, they're draining into the coronary sinus, that makes a prominent vein, and so the septum primum stays behind it. Coming to the ventricular chambers, they are equal in size, as I have already discussed. This is the moderator band. There is apical insertion of the tricuspid valve. These are all markers for right ventricle. Left ventricle is always smooth. It has bicuspid mitral valve and it forms the apex of the heart. The left ventricle always forms the apex of the heart. So these are the atrioventricular valve, the mitral valve on the right and the tricuspid valve on the, mitral valve on the left and the tricuspid valve on the right. They opens and close, move freely, and the tricuspid valve leaflet insertion is closer to cardiac apex than the mitral valve, and those difference makes the offset. Okay, so we have covered everything about 4-chamber view. So these are the few images which were there in the ISWOG guideline, and this is a small video where you can see the VSD. Actually, we find a VSD, and then when we put the color, when you see the mixing of blood from the one ventricle to the other ventricle, then we are confirmed that it is a VSD. So can you see from the stomach? So there is a perimembranous VSD. This is a AVSD video. Can you find out? This is atrioventricular septal defect. Here we could not find the septum primum, and this foramen ovale is very large, that is more than 8 to 10 millimeter. Then, and there is missing of septum primum, as well as there is perimembranous VSD. So this is atrioventricular septal defect. Can you see? Then next is, this is hypoplastic left heart. So to summarize the 4-chamber view, that is a normal size heart in the chest.
Please show us the hypoplastic left heart. Just slide previous one.
If the time permit, I can show you the video. It is just
Okay.
I have taken from the ISWOG site only. This is the left heart. This is the spine. The close to the spine is the left atrium, and then it is the left ventricle. So this left ventricle is hypoplastic left heart, and this right ventricle is normal heart, and this is right atrium. So this is to summarize the 4-chamber view. The size is normal heart in the chest, transverse plane of the fetal chest with one complete rib on each side of the fetal lateral chest wall. Descending aorta in front and to the left of the fetal spine. Apex of the fetal heart pointing to the left upper chest at about 45-degree angle. Both atria are equal in size. Foramen ovale in the midsection of the atrial septum with leaflet of foramen ovale in the left atria. Two inferior pulmonary veins should be always visible in the opening into the left atria. There is patent atrioventricular valves, tricuspid valve leaflet, septal leaflet more apically inserted than mitral valve. Ventricles are equal in size and contractility, intact interventricular septum and moderator band in the right ventricular apex. So these are the common things we need to see in the 4-chamber heart. So what are the plain anomalies? 7 anomalies excluded. I have already told. Any type of situs abnormality, situs inversus totally, or situs ambiguous, ectopia cordis, all univentricular valves, hypoplastic left heart, right heart, any type of septal defect, whether it is ASD, VSD or AVSD, any pericardial effusion. You should remember 3 things, that echogenic intracardiac focus is also a normal finding. Minimal pericardial effusion is also a normal finding. You have to measure the pericardial effusion. If it is between 2 to 3 millimeter, it is a normal finding. Only if it is more than 4 millimeter, you need to note down as pericardial effusion.
Dr. Gangadhar, आपण म्यूट करंतु. Dr. Gangadhar, म्यूट करंतु.
So please see that chamber asymmetry in the third trimester, minimal pericardial effusion, and the echogenic intracardiac focus. These three things are always normal. Chamber asymmetry is very common in the third trimester. So if you are seeing chamber asymmetry in the third trimester, don't be apprehensive. It is a normal finding. Chamber asymmetry in the third trimester, minimal pericardial effusion up to 2 to 3 millimeter, and the echogenic intracardiac focus, that is EICF in the left ventricle. These three are always normal findings. So don't make your patient apprehensive. Next we come to left ventricular outflow tract, that in short we call it as LVOT view. So left ventricular outflow tract, why it is important? This is when you, from the four chamber view, if you point the shoulder, if you rotate the shoulder, rotate the probe towards the fetal right shoulder, that is at an angulation of 45 degree, you will clearly get LVAO, that is left ventricular outflow tract, that is left ventricle in connection with ascending
Madam, please
aorta.
again. Madam, please again.
When you in from the four chamber view, you have to rotate the probe very slowly to 45 degree towards right shoulder, fetal right shoulder. If you rotate this, you will get LVAO view, that is left ventricular outflow tract view, that is left, it is continuation from the left ventricle to the ascending aorta. What you must see is the septo-aortic continuity. There should not be any defect between the septum and the aorta. This septo-aortic discontinuity is a marker for many diseases. I will let you know. So what is a septum? This is the interventricular septum that separates right ventricle from the left ventricle. You can see the septum, that is interventricular septum. This interventricular septum is in continuation with the ascending aorta, wall of the ascending aorta. Vessel wall is in continuity with the interventricular septum. This is known as septo-aortic continuity, and that is very important for tetralogy of Fallot, for CAT, common arterial trunk, for DORB, there are so many conditions where there is defect in the septo-aortic continuity. So what you must see is septo-aortic continuity. If the septo-aortic continuity is not there, there is overriding of aorta or not.
And the angle also, angle.
Yeah, that you need to see very particularly, because you may not diagnose tetralogy of Fallot or CAT or DORB, but identification that continuity is maintained, that means you have ruled out all these anomalies. That is very important. So septo-aortic continuity is very utmost importance on the basic evaluation. When we do for some observer it could be a CAT, for some observer it could be a tetralogy of Fallot. But to identify septo-aortic continuity is important. You may not diagnose tetralogy of Fallot, but if you have diagnosed that there is discontinuity in the septum, sorry, discontinuity in the septum, discontinuity in the septo-aortic valve, that means you have ruled out so many diseases. That is the importance of LVOT. So in LVOT, what are the things we need to see? You see how this is overriding. there is discontinuity in the left ventricle outflow tract. Can you see the difference? Here right ventricle blood as well as left ventricle blood, both are coming together and there is aortic override. So that is the significance of the aortic override. So this is the video. This is the video, a small video. Can you see? There is there is septo-aortic discontinuity. In the color flow also you can see that there is a blood from the left ventricle and blood from the right ventricle. They mixes and goes forward. So there is septo-aortic discontinuity. You can see the thing again. This is the 4-chamber heart, and when we tilt, we could see there is septo-aortic discontinuity. So the septo-aortic discontinuity can lead to overriding of aorta, and there are so many conditions where overriding of aorta occurs, like DORB, TGA. Also, you can diagnose tetralogy of Fallot. So this plane is important mainly to rule out the overriding aorta like structures like tetralogy of Fallot, CAT, and the DORB, and also you can differentiate TGA. How you can differentiate TGA? Because in TGA there is transposition of great arteries. So when you see LVAO, you can find that instead of aorta there is pulmonary artery bifurcation. So you will able to know that there is PGA instead of normal. This is the right.
Dr. Madhumita wants to know what is override. Tell her what is override. Override is aorta is sitting on the both sides of the LV and the right ventricle and the left ventricle. If you see the image, aorta is sitting on both sides. It is sitting in the middle of the, as if the septum upare ghoda bhalya basi chhe.
Yes, override is normally there is this septum is in continuation with the ascending aorta wall, vessel wall. That is septo-aortic continuity. So any discontinuity, this aorta will override the right ventricle outflow tract. So therefore we are telling that it is overriding of the aorta. Because normally there is no overriding and this septo-aortic continuity will go. If there is overriding, what overrides? This aorta overrides the right ventricular outflow tract. That's why we are called it as overriding. Is it clear, I believe?
It is sitting on both LV and RV, both.
RV, yeah.
Both. Anyhow,
So,
go ahead.
Next is the plane 9, that is the right ventricular outflow tract. The right ventricle, we can see it as here, and there comes the pulmonary valves. Beyond the pulmonary valves, we get main pulmonary artery that we write in short as MPA, which further divides into left pulmonary artery and the right pulmonary artery. So remember this right pulmonary artery, they encircle the ascending aorta. This is the aorta. So it remains close to the aorta. This is the right pulmonary artery. And this left pulmonary artery, they form the ductal arch and they go and unite with the aorta, descending aorta. So this is the left ventricular outflow tract images. How you will get? How you will get? You have got the 4-chamber. First you have to get the situs, move cephalad to the baby, just 1 millimeter, 2 millimeter. It is not a move that you can just move the probes over, because heart is a tiny structure and everything you get within 1 to 2 millimeter movement. So when I ask you to move cephalad, you have to just minimally move for 1 to 2 millimeter. That's all. You cannot move long. And then you need to rotate the probe towards right fetal shoulder to get the LVOT view. From the LVOT view, if you draw perpendicular, that is 90 degree, from the rotate the probe immediately from LVOT to 90 degree, you will get RVOT, this view. Okay, if you face any type of difficulty, we will be there near you. Sooner we will go to the fields also to train you, to hold your hand. Please, you try, you practice, so that when we will come, we will hold your hand and we can teach you better. And in case if you are trained in that, please let us know. If you are facing any difficulty, we are always there to help you out. And it is very simple, everyone can do. Last is the plane 10 or the 3-vessel trachea view. In 3-vessel trachea view, that comes only when you go from the cardiac situs to the 4-chamber view. Next view that comes is the 3-vessel view or the 3-vessel trachea view, where we can see, previously it was known as 3-vessel view, because we could able to see only 3 vessels, that is pulmonary artery, aorta and SVC, from left to right. Extremely left is the pulmonary artery, then is the aorta, and then is the SVC. And that view is coming as dash dot dot. The aorta and the SVC came as a dot dot structure, and the pulmonary artery come as a dash view. Dash view means pulmonary artery is going to descending aorta, forming the ductal arch. So this is a dash view, but the aorta and the SVC are coming as dot dot view. So slowly, if you move further upward, you can see this aorta also getting draining blood to the descending aorta. Sorry, this aorta is also going to the descending aorta. So you will get 2 flows forming the V-shaped structure. Anything which is interrupting in between, it could be some abnormal thing. So you have to remember this V. This V, what we see in the first this V is also we are seeing in first trimester. In first trimester, we see inflows as 2 parallel lines and outflow as V structure, that is tick sign. So those V's are due to this aortic arch as well as from the ductal arch. That makes the V. So the first arch is the ductal arch, which is extremely left, and then is the aortic arch, and then is the superior vena cava. And on the back we see a echogenic structure that is known as trachea. So this is also known as 3-vessel trachea view. So where it is coming and meeting in the descending aorta. So you know this is pulmonary artery, this is ductal arch draining to the descending aorta, and this is aorta, and where the aorta meets the descending aorta, it is the aortic isthmus that you might be heard in when we are taking Doppler in a very hypoxic fetus. We used to take this 3-vessel view and we used to put our Doppler here in the aortic isthmus to see for the aortic isthmus Doppler. That is the final stage for fetal hypoxia. So that is the significance of aortic arch and the aortic isthmus. This is the superior vena cava. Just in front of this 3-vessel view, we see a mildly hypoechoic structure. Can you see this? And this is nothing but a thymus. So whenever there is absent thymus, you will see this sparse structure, that is the 3-vessel trachea view, will come closer to the sternum, just next to the sternum when there is absent thymus. And absent thymus is a marker for 22q11 microdeletion. So whenever you are saying tetralogy of Fallot or any conotruncal anomalies with absent thymus, please do amniocentesis and send it for FIS for 22q11 microdeletion, or you can directly send for chromosomal microarray. So thymus is very important for visualization. For every 3-vessel trachea view, you have to see the 3-vessel trachea view is normal or it is in close proximity to the sternum. That way you can differentiate the presence and absence of the thymus. There is another, you can put the internal mammary artery and that will go surrounding the thymus. That also you can do. But this is the easiest ways to diagnose the presence and absence of the thymus. So this is the...
Preeti, go to previous slide. See, all these 3 vessels are situated always to the left of the trachea. It has an implication. Please tell.
Yes, and the diameter also, that is more for P, then lesser for A, then lesser for S. It is not equal. Highest is the which is present on the left side, that is on the pulmonary artery, and the width goes slightly lower for the aorta and then slightly to the SVC. So when you see the 3 vessels, the bigger one will be pulmonary aorta, and then aorta will be smaller than pulmonary artery, and the SVC will be still smaller than the aorta.
And they are always, all the 3 vessels are always to the left of the trachea.
Yes, yes, sir. Yes, sir. And this is the pulmonary artery, aorta forming the V. We have put the color. So always the pulmonary artery and aorta will have the same color. And this is the superior vena cava, which may have opposite color. So this is the thymus. Can you see this hypoechoic area in front of the pass view? You will always get this in the pass view only. This is PAS, pass view. This is the trachea, echogenic structure which is present close to SBC. So pulmonary artery, ascending aorta and the superior vena cava. This is the thymus. So these are the, what are the things we detect in the 3-vessel trachea view. So any aortic stenosis, pulmonary stenosis, transposition of great arteries, truncus arteriosus, HLHS, right aortic arch, interrupted aortic arch, tetralogy of Fallot, almost many lesions. If you combine, if you wholeheartedly you do the situs and the 4-chamber view and the 3-vessel trachea view, you can diagnose 70 to 80% of the cardiac anomalies. So that important is just a little enhancement from the abdominal situs to the 4-chamber view and bit higher to the 3-vessel trachea view. So if you do only these 3 planes, you believe me, you can rule out 60 to 70% of the major cardiac anomalies you will able to diagnose, and you will able to send. Able to save the infant mortality rate. That is how we are targeting for. So thank you so much. These are the lesions. I will show you it.
Hello. Hello, Preeti madam. What is the probe movement for 3-vessel view, madam? Actually,
probe movement for 3-vessel view. First, you go to cardiac situs, move a bit around 1 to 2 millimeter. You will get 4-chamber view. From the 4-chamber view, you go cephalad. Like how you have moved from the cardiac situs to get the 4-chamber view, what you have done? You have moved cephalad. 1 to 2 millimeter cephalad you have moved, and you have come to visualize the 4-chamber view. Similarly, from the 4-chamber view, you still move cephalad, you will get 3-vessel and 3-vessel trachea view.
Thank you, madam.
When you are going higher, you will see 3-vessel view, and from there you tilt the transducer towards a little left, little downwards, you will achieve 3-vessel trachea view. I think the probe movement will be shown to you on site also. If any of the participants are attending tomorrow, then we can show them on the simulator there.
Actually, abdominal situs, 4-chamber view, 3-vessel view and 3-vessel trachea view, all are transverse movement only. For getting the outflow tracts, we have to rotate bit to get LVOT. And once you get the LVOT, you have to rotate perpendicular or 90 degree to the probe to get RVOT. So it is very easy. Please practice. And if you have any doubt, you can ask. It is very easy movement. Just you have to go very slow and you have to move your probe only 1 to 2 millimeter, not more than that. Because heart is a very tiny structure, we cannot move for 4-5 millimeter. Just little bit of hand movement towards cephalad, you will get from the situs, you will get 4-chamber view. From the 4-chamber view, you will get 3-vessel and 3-vessel trachea view. From there, you rotate towards the fetal right shoulder, you will get LVOT view. That is left ventricular outflow tract, where you have to see for the septo-aortic continuity. And from there, you rotate 90 degree of perpendicular axis rotation. Then you will get the right ventricular outflow tract. So your fetal heart examination is complete. Within this 5 minutes, 5 minutes of rotation, it will be complete. If you practice every day for 2-3 patients, definitely within 5 to 10 days, you will be able to take all the shots. Okay, because this was a basic talk, so I kept only very minimal thing. I hope this will help you. At least you try all these planes. And thank you so much for your patience hearing.
Thank you very, very much, Preeti, for a very lucid. It couldn't have been any better. And this is all that we need to know. Because if higher things are put
Thank you,
into
madam.
our brains, then we will be a little confused. So all of us, all specialists in our facilities, I'm sure you must have gained a lot. I think there was quite a good attendance today. It should have been still better, although I don't know what it was before. So this has set the ball rolling, I think. And we will go towards the next simulator training. And then when we are visiting you on site, we will take a checklist and we will mark you. So please, after the simulator training, and when you're not taking the simulator training, please revise all the presentations time and again. So the state wants to know your capability, how much of capacity building has occurred through these online courses, so that when we go on site, all the trainers, all the on-site trainers will take a questionnaire, and you will have to fill that up so that we can assess how much you have learned. And those who are not attending these very, very useful sessions, although the state demands you to attend it, you have no option but to attend. You will be identified, and the directorate will note your non-attendance and non-performance, and it is up to them to take the next course of action for you. But you have to attend. There is no option. So I'm sure, even if the attendance was quite good today, it should have been much better, because there are many more specialists who are not attending. We have got feedback. They will not attend, but they will go and crowd around those who are attending to learn from them. Why aren't you attending when the expert trainers are giving you the first-hand online training? Why can't you watch it in your sets? If you watch it in your sets, attend the pre-poll questions, attend the post-poll questions. All these are designed to upgrade your capacity. So we are not leaving you. We want you to deliver, and we want you to reduce maternal and perinatal mortality in our state. There is no way out. Professor Khurana and Hashmukh sir, if you want any comments, we can go in for post-poll now.
I think I thank Dr. Preeti Dubey for a nice sharing. One of our friend asked about the plane. Now in this image, can you see the screen? Ma'am, can you see my screen? Is my screen visible? Hello.
Yes, sir. It screen visible, sir.
Okay. Now look at this. This is the 4-chamber view. So this is the place of the transducer. This plane. This is 4-chamber view here, and this is the first plane from the stomach. When you come up from the stomach, this is the first one we will see, the cardiac chamber. And look, this area behind the heart, this is the crux. In case of AVSD, it will be as if somebody has given a bite here. Somebody has chobai kari eta khai deisi bhaliya desibo eta. Hala, eta AVSD re. Now, a area behind the heart jo achi, this is the left atrium. Descending aorta is just behind the back wall of the left atrium. There should not be any other vessel here. In between the descending aorta and the left atrium, there should not be any other vessel. If you see any other vessel, it will point to total pulmonary venous drainage defect, anomalous, that becomes the pulmonary vein ta anomalous thibo, tahale ethi gote extra vessel disibo. So this is one of the critical region. Crux is a critical region. The walls, apna kon karibe, jetebele wall movement ta dekhuchanti, setebele apna taku freeze kari sine loop re nela belku apna wall ro movement guda ko dekhi paribe. So you can see whether
point thi Hasmukh sir se jo ye ta hypoechoic shadow of the left descending aorta, if there is another small hypoechoic area,
yeah, that could be
right, it may be the esophagus.
Esophagus, but
Peter swallowing
swallowing movement jadi disibo, but it will not be always. It is a transient thing. It is a transient thing. So that's why I'm not mentioning. A vessel will be always, it's a permanent structure. So I think these are the critical areas of the heart. And yeah, and this again you see Preeti had nicely shown the angle will be lost in cases of, see, in LVOT, what is the critical thing we see? First thing is we see this continuity, and we see that this left ventricle and the ascending aorta has an angle, and there should not be any flow coming from the right ventricle to the aorta. No flow should come from in that case there is a perimembranous defect. So this is one of the important thing, and somewhere here there is a aortic wall. Now what we have to do is we go behind, above the wall, behind in the chest. This aorta, how do we know that this is aorta? Aorta does not divide at this level. If there is a dividing vessel here, it is pulmonary artery, because pulmonary artery will divide immediately after coming out from the ventricle, but from the right ventricle. But aorta does not divide immediately. It goes far behind, and then it curves toward the right side, and then it divides. So there should not be, this aorta should not be dividing. If it divides, it points toward TGA, transposition of great vessels. So these are the things we have to, these are the critical areas we have to look for. Now in this view, RVOT, we will this is the aorta, and the wall movements you will be able to see. This whole plane is taken at the level of the aortic wall. So you will always see the aortic valve here. And this is, as Preeti has already told you, this is the right one. So it curves around the aorta, and this is the left one, which goes toward to form the ductus. This is the ductal vessel. So I think I told you about the area behind the heart, the LVOT. And remember, Preeti had mentioned about the axis. Axis is very important because cardiac axis, in 72% of the cardiac defects, axis will be abnormal. Please remember that. So if you find that, yes, axis is beyond 65 or less than 25, then look for the entire, look at all these areas very carefully. In this view, look, here is the trachea. All the three vessels will always be toward the left of the trachea. See, because sometimes it happens in some anomalies, the trachea will be in between. You know, there are and also remember what is the importance of the aorta, descending aorta. We say that it is always sitting toward the left of the spine. If it is toward the right of the spine, then there is an abnormality. Then we think of right aortic arch. So that please remember. I think, yeah, this is, and most of the things Preeti has described so nicely. I think, yeah, she did an excellent talk. I think because of the paucity of time also.
I think post-poll should be launched.
Yeah, we can. Yes, we can now.
Sambit,
Hello.
sir.
Hello.
Shall we launch the post-polls?
Hello.
आगे मैडम launch कर दो.
Hello.
आगे कौन तो some.
हाँ प्रीति मैडम मोर गोटे डाउट अछि मैडम, हाउ टू इम्प्रूव द कार्डियक इमेजिंग, हाउ टू गेट द बेस्ट ये माने कार्डियक इमेज. Actually you are just seeing the cardiac image, so you cannot getting the best image. So how to improve?
Sir, you
Preeti, are you there?
Yes, sir. You keep on doing, sir. You send me. I will say you whether you have taken a good image or not. You try. You don't quit, because initially when we used to do, we were also very scared whether the same plane will come or not. But you keep on doing. Only practice will make you perfect, sir. You
Thank
keep
you,
on doing.
I think Preeti, they should, if they have the option, they will choose the fetal echo and then widen the picture and zoom it. Then
actually madam, when I am just focusing, I have a problem that when just magnifying the image, it is just blurring. The image is blurring. So how to get the best image?
You go to cardiac preset or whatever machine you are having. You call those people. They will come and they will make a cardiac preset. So whenever you go to a cardiac, just press that cardiac preset. Go to that cardiac preset. They will have everything there. Means those whatever we require. High frame rate, very good contrasting, high contrast structures. So everything will be there in your cardiac preset. So you go to cardiac preset and you take. Instead of taking in normal place. And most important is zoom the image. You use the zoom box, put it over the chest, zoom the image. So that in the field nothing should be there, only the two lungs and the heart. So that you will clearly see all the structure. You do once. If you are facing any problem, you can do a video call. I will just guide you how to do further better.
Thank you, madam.
Ashok sir, can you have anything to add to that? To
Yes.
Devendra Babu's question. Yeah.
You know,
Devendra.
Of course, I must congratulate Preeti for this wonderful talk. I wish I was younger in my training, and then I would have used her as my teacher, and she would have held my hand and made sure that I make no mistakes. So that would have been marvelous. But the reality is that now we have to tell others how best to do this. And the first thing, of course, is to make sure that the heart should be done when the apex is pointing anteriorly. You heard that description from Dr. Preeti. So if you don't have an apex pointing anteriorly, which means that the fetus is not lying supine with its back towards the back of the mother, then you will not get ideal cardiac. And so that is the first prerequisite. And the thing that you do then is that the moment the fetus comes with the heart pointing anteriorly, you study the heart. Don't wait to go through the cranium and then the neck and then the vertebra and then the face and then do the heart. No. If the heart is in ideal position, you handle it there and then, and you finish your cardiac evaluation. The second step, as you heard, is to have a preset which is correct. Most machines don't have a preset which has been set properly, and you have to call on the applications expert. We used to make phone calls to applications experts. We now understand that all these corporates do not listen to us. All you have to do is to send an email. An email is illegal that you have to answer, and they have to then cooperate, and it's a record. So that's the second thing. And then you make sure that you go through each one of these, and that the study is not complete until each one of these is done. Once the fetus is in the right position, there is no way that you will find any of these difficult. The problem is struggling because of the fact that the fetus is not in the right position. And then, of course, some of us try and look at the valves when the fourth chamber is in a lateral view rather than apical view. It will not show. The way to look at the interventricular septum is in the lateral fourth chamber view, but the way to look at the fourth chamber view with the crux of the heart is with the cardiac apex pointing anteriorly, preferably 10 o'clock or 11 o'clock position. So once you're doing that and you have removed your mental block, that's the most important thing. So A, you know that you can do it. The second thing, that you can do it well, because now you have been set on the track. The third thing is now just get down to doing it, and you will do it well, I know for sure.
Thank you, sir.
Ashok sir, any more comments about the subject?
No, I think they were very lucky to have such a beautiful talk today. And I did not record this for myself, but I would have loved to record this for myself to keep learning from it.
Thank you so much. Yeah.
Only I get little angry when the specialists out there are missing out on this and not attending, being so lazy. No, in Odisha, laziness is our trait. They're just satisfied with their deliveries and cesarean sections and hysterectomies. So we'll have them do it at any cost.
Yes, yes. We have to inspire them more.
So those who are attending, please inspire your colleagues to attend. They cannot be your competitors, and nobody is a competitor here. Everybody has to be in one league to deliver pretermaternal health to our women. So post-poll questions, is everybody answering? Please answer. It's in your interest. See how much you have learned.
Ashok sir, those who have not attended, it will be their wasted time.
True, I really feel so sad. But I think we will manage. We will manage to inspire them.
Because all the topics are going great, and with your guidance, it is really very inspiring. Okay. Yeah, every speaker.
A pleasure.
Sir, sir, hello.
Yes, yes.
Good morning, sir. Good afternoon, sir. Sir, what are the deformities we can find in the three-vessel tract view, three-vessel trachea view?
You know, there is very few deformities, very few abnormalities, we should call them, that you will not find in the three-vessel trachea view. So the two things that you're not likely to find is a pericardial effusion and a ventricular septal defect. For everything else, there are enough changes in the three-vessel view. So really, today, the three-vessel view is a window to the rest of the heart. When I see a three-vessel view, it is my primary view, and it reassures me that it is unlikely that something serious is the matter with the heart. And it reassures me. So in fact, I start with the three-vessel view first and move backwards to the four-chamber view. It is traditional to do the four-chamber view first, but believe me that almost everything shows up either as an abnormality of vessel number, or an abnormality of vessel size, or an abnormality of vessel relationships, or an abnormality of direction of flow. And with that, you will actually be able to pick up over 89% of cardiac anomalies. It's really the best view to use.
In one of the lecture of Abu Hamad, he had said that, okay, see, the 3-vessel view is the only view required for detecting heart abnormality. And he said that when I told this, a lot of people, they said, no, you should not have, because you are now ignoring the other views. So he said, but in fact, 3-vessel trachea view is really, really great, because those, as Ashok sir says, Ashok sir is an expert. So with only 3-vessel trachea view, as he said, only 2 he will not be able to rest everything he can. He can point out the abnormal. Yeah, I agree fully with that, because I have been listening to Ashok sir, then Rabi Shavi, Professor Abu Hamad, and it is 3-vessel view is a very important chapter actually. And I think that Ashok sir, I had shared that lecture to a lot of friends here.
Yes.
And they're very, very happy about that.
Yeah. Beautifully highlighted lecture.
Yeah. And the 4-chamber one, which he does, he spoke it sometime, I think, in the ISWOG recent abnormality. Yeah. Recently, we had one webinar. I think in that he spoke. The 4-chamber, I was asking you, where is this lecture? You know?
Yes, yes.
Yeah, that one he repeated. He repeated that actually.
Yes.
So participants, please attend all the post-poll questions.
Those who wants to know more about cardiac, those who are doing all this basic, they can join us in Fetal Cardiocon, which is going to be held in New Delhi, Gurugram, on 25th to 26th of August. So if you want all those advertisements, I can forward you. If those who are interested can join from there. And Professor Rabi Choi is coming. So from basic to the higher level, everything you will get it there.
Yeah, I think Dario is also coming, sir. Is it?
Yes,
Dario Palladini.
coming, and then there is Orhan Ozun,
Oh,
who is like Preeti. He
He's
will
from
make
UK.
sure that everybody learns everything.
Yeah.
He will catch hold of them, whether it is morning or afternoon or evening, and say, come here, you don't know the answer to this, here is the answer to this. So all these 3 people, and there's a lot of basic echocardiography there, a lot of basic cardiac evaluation. There is genetics also, there is all the high-end technology, but 50% is devoted to basic evaluation.
Right. And Ashok sir, I had suggested that those who are beginners, they can take this Mediscan manual.
It's an excellent manual.
Yeah,
it's an excellent
this
manual.
one. And those who want more advanced, I have suggested the 4th edition of Abu Hamad and Rabi Shavi.
Yes, absolutely. I saw that.
I have written it on the chat box. Yeah.
Yes. And you see, Dr. Indrani Suresh's book is illustrated and labeled. So when you're looking for anatomy, you find it ready, absolutely sitting over there. So this book you should keep inside your ultrasound room, because it instantly gives you the anatomy.
Hope everybody is answering the post-poll questions, because we'll stop it and then we have to discuss each of the questions.
Already answered.
What is the percentage?
Madam, 36 participants have responded to post-orientation poll questionnaire.
Why are they so slow? Quickly finish it, and then in 5 minutes, I think we should stop, and then each of the questions will be discussed by Hasmukh sir.
Hasmukh sir, how to get the medicine manual?
Yeah, I think, look, I got it from, possibly from Amazon, I believe. But what you can do is, I am giving you my email here in the chat box. You can write to me. I will share it with you.
Yes.
I think I got it from Amazon.
No, now we can discuss.
There
the
are several
post-
bookshops now where it is available.
Yeah.
Every bookshop has started keeping it.
Right.
And there you have Dr. Hasmukh Lal's address, drhasmukh@gmail.com.
Sir, even Oliver will have it. Oliver will
Oliver
also
has
have
it,
it.
yes. Oliver
Yeah,
keeps
Oliver.
sample copies, yes.
Yeah. So I think I will share the complete address and the phone number of Oliver.
Yes.
Let me share. You can ask him. I am sharing his number here.
Yes.
Oliver.
Yeah. Oliver is a bookseller who sends things by post, and you can transfer the money to him by bank transfer or by check, whichever you find more convenient. And he always gives fabulous discounts because there is no middleman involved. So he's almost like direct from publisher to the user. And the name is Oliver, and very, very useful person. In fact, you will find a huge discount even on the 4th edition of Rabi Shawi and Alfred Abu Ahmad's 4th edition of the echocardiography book. And you will invariably find it very useful to be in touch there.
I have shared the telephone number of Oliver, 98922 51937.
Yes.
98922 51937. It is there in the chat box.
Yes.
So now we can discuss, sir.
Yeah, we can discuss. Okay, question number 1. The
Stop
right
post
answer.
polls.
Okay.
Post poll stopped.
Yes,
Okay,
madam.
madam, end कर दीजिए.
Okay, let's discuss.
Okay. So which of the following is true about normal abdominal situs while determining the situs? So as Preeti had shown in the diagram, when we intersect the abdominal circumference view into two halves, the stomach is on the left side, the descending aorta is to the left of the spine, and IVC and gallbladder are on the right side. So that is the correct answer.
So what is the pre and post poll difference, Sambit?
Madam, pre and post orientation difference is from 60% to 88% improvement.
Very good. Good jump.
Yeah. Now question number 2. Which of the following statement is false for 4-chamber view? All the 4 pulmonary veins are entering into the left atrium. So that is true. The flap of the foramen ovale opens into the left atrium. That is also true. Both the mitral and tricuspid valve attachment on either side. That is also right. It is forming part of the crux. And septum primum. No,
Yes,
we
sir.
have got. So all the 4 chambers are well seen.
Sir, C is the answer.
C is the answer.
C is the answer. Jump from pre and post poll.
So, madam, pre and post orientation is from 44% to 80%.
Very, very good. Great.
Then the crux.
So Preeti has done a very good job, and learners have also paid a lot of attention. Congratulations to both. Next.
Question number 3. The crux of the heart consists of all except mitral and tricuspid valve is a part of crux on either side. Septum primum is a part of the crux. Secundum is not a part of the crux because secundum is lying on the other side. It is toward the other side of the above the flap of the foramen or the valve. So The interventricular septum is a part. Secundum is the exception. That's not. That's the
Right answer.
right.
The pre and
So,
post
pre and
orientation
post-
difference, madam, difference is from 38% to 84%.
Fantastic. Good,
Yeah.
Preeti and learners. Good.
Now, question number 4. Which of the following is not a normal morphologic characteristic of the right ventricle? Which of the following is not a normal morphologic characteristic of the right ventricle? Moderator band is the characteristic of right ventricle. Pulmonary artery forms the outflow tract. That is also right. I think I'm something. Apical insertion of the AV valve. That is also
Right.
because the right way, the tricuspid is more toward the apex.
So best response is bicuspid AV valve.
Bicuspid is not, because it is a tricuspid valve. It has 3 cusps. So bicuspid is the wrong answer. I mean the right answer. Yeah.
Right
Bicuspid.
choice. Right choice.
Yeah, right side. Yeah.
Madam, pre and post orientation improvement is from 62% to 94%.
Again, very good.
Yeah.
Next.
Next is, which of the following is a true statement about the fetal heart? The apex of the heart will be angled to the right of the midline. The apex of the heart is the portion closest to the spine. The normal fetal heart will be approximately 2/3 of the fetal chest. That is the wrong answer. And the chamber closest to the fetal spine is the left atrium. That is the right answer. Because chamber closest to the fetal spine is the left atrium. It is the most posterior one. So it will be closest to the spine. 84% of the 84% have answered in the post-post.
Sir, pre and post difference is from 62% to 84%.
Good. Again, improvement is there. Question number 6. All statements are true for 3 vessel trachea view except pulmonary artery is the most anterior and larger in diameter than aorta. That is the right thing. It is normal. Ductal and aortic arch are equal in size. It is also right. Pulmonary artery and aorta are on the right side of the trachea. I had mentioned this, that pulmonary artery and aorta has to be on the left side of the trachea is the thing. And thymus is seen anteriorly in the right. So I think the pulmonary artery and aorta are on the left side and not on the right side.
That's the correct answer for except
60%. 60%. Yeah.
Pre and post poll.
From pre and post improvement is from 40% to 60%.
Yeah.
Again improvement. 7.
Question number 7. Which is not true about LVOT? LVOT means left ventricular outflow tract. There is a mitral and aortic continuity. We have forcefully said that there has to be normally a continuity. Aorta is seen within the left ventricle. Yes, that is also true. There is an angle between ascending aorta with ventricular septum. That is also true. Aorta and its branches is seen in this view because aorta, as I had mentioned this very specifically, aorta does not divide at that level. 72% of the people have answered right. Aorta has no branches in LVOT view.
And sir, the pre and post orientation difference is from 32%, 33% to 72%.
Very good.
Very good.
Now, question
number 8 is we have to pick the true statement, which is a true statement. So, the 4-chamber view can look normal even if the fetus has major congenital heart disease. Preeti has already told us that 4-chamber view only 50% will be seen, other 50% cannot be seen. Three vessel view can detect all anomalies of the heart. Well, that most of the anomalies of cardiac defect are, it can detect almost. So for viewing the heart completely, transverse move from abdomen to the heart will cover all the planes 7, 8, 9, 10. That is also true because Preeti has demonstrated this. All are true is the right answer. All the statements here are true. 60%.
Madam, pre and post orientation difference is there is a dip in the post orientation response, that is from 71% to 60%. There might be some confusion.
So only option A is correct because option B is three vessel trachea view can detect all anomalies of the heart. It cannot detect all anomalies.
Not all, most of them. Most of
so
them.
it is wrong. And for viewing the heart completely, transverse move from abdomen to heart will cover only plane 7 and plane 10, and plane 8 is LVOT and plane 9 is RVOT. For that axial movement we have to do. We have to do angulation.
Angulation, yeah, angulation has to be.
So it cannot be only transverse move. From transverse move we can see situs, 4-chamber, 3-vessel view and 3-vessel trachea view. That much we can
The
see.
correct answer is A.
Correct answer is A, not B.
Okay.
So
Thank
what
you.
is the jump in A? Correct jump in A?
Madam, the response for A option is 10% to 12% only.
Oh, so actually on the whole they were confused. If they had it needed a little closer look. Anyway, it doesn't matter. Now it is cleared out. The answer is clear now. Hope everybody is listening.
Thank you for Preeti for correction. Yeah, for correcting me. Even I had attempted it wrong. Thank you very much. So I didn't get 100% actually. Thank you. Question number 9. What is true about 4-chamber view? Now I had already told that it is the first visible plane while sliding up from abdomen. There should be a full rib on either side. This is also true. It is an axial plane somewhere at the level of the 4th rib. That is also true. And all of the above is the right answer.
So pre and post pole jump?
From pre and post difference is from 83% to 90%.
The question is good and it was also quite suggestive that all of the above will be correct. So, but the jump is good also.
Question number 10. Which is false about RVOT? Right ventricular outflow tract. Now on sliding upward from 4-chamber view, we will get RVOT. The second one is right division of the main pulmonary artery curves around the cross section of aorta. This I had already told and also shown in the figure. And aorta is seen in cross section with its walls. I had also mentioned that the walls will be visible. And right branch of pulmonary artery forms the ductus arteriosus. So I think the right, this is.
Best choice is A, I think.
I think all of the thing should be very. This set has gone.
No, Preeti, please clarify.
All of the above with the. Sorry, this is.
No. Which is false? False is A, I think.
Is false about right ventricular outflow tract. So RVOT. On sliding upward from the 4-chamber view, we will get RVOT. We will not get RVOT. We will get situs, 4-chamber view, 3-vessel view, and 3-vessel trachea view. For outflow tracts, we have to rotate the probe to an angle. Okay, so we will not get on the transverse plane. We will have to angulate for both the outflow tract, LVOT as well as RVOT. So this is wrong. Number
so
2
is the best choice.
Right division of the
Right division forms the ductus.
Right division of the main pulmonary artery forms the ductal arch. It is always the left pulmonary artery and not the right one,
Not
which
the-
makes the ductal arch. So
Yeah.
this is also wrong. Third is aorta is seen in the cross section. Yes, we have seen that RPA comes in close proximity with the aorta. So C is correct. So the 10th question was which is true about RVOT. So option C is correct. Only option C.
Madam,
Not
the
A.
question was which is false about RBOT.
Yeah,
No,
the
no.
question was what is for.
I think there was something wrong in the question.
I
Question
think
has been wrongly formulated. That means
Yes.
which is false means they have to choose the false one. So
Yeah, I think-
in that case, A will be the correct answer. A will be the best choice. Because on sliding upward, fourth chamber view, we don't get RVOT.
is it an,
We get,
true about
isn't it?
RVOT?
So if all the other three are correct, then number one should be the best choice. That means as the question is asking you, what is false?
Madam, last one is also wrong. Right branch of pulmonary artery form the ductus. That is wrong.
That is wrong. Yeah.
Yes.
Then
It is
it has more than two answers. That means
which
Yes.
are false. Yes, yes.
so the question configuration from our side as organizers.
From my side, actually, I
beg
had changed
excuse.
this question. Yeah, I made a mistake. I think I had instead
what
of
is
false, I should have written true. Yeah, yeah, yeah.
So Hasmukh said,
Anyway, sorry
he
about
is the
that.
culprit.
We will, yeah, we will give you full mark for that. Don't worry.
Okay.
Thank you so much. Yeah.
Clarifying.
Thanks, madam.
So I think we shall end here.
Yes, we've had an excellent session today, a grand teaching session, and I have enjoyed being here with you all. My best wishes always, and I look forward to next Friday.
Thank you, sir. Thank you for
We'll be
attending.
expecting
Yeah.
Thank you. Thank you very much.
Namaste.
Next Friday, what is the topic, sir?
It is about
Urinary tract.
normal and abnormal urinary tract. Madhumita Mahanti. She is the speaker, presenter next week. Yeah.
Thank you, sir.
Okay.
Thank you, sir. Sambit sir. Hello,
Aଜ୍ଞା,
Sambit sir.
sir ମୁଁ ସବୁ PPT ଗୁଡ଼ା share କରିଦେବି।
ठीक है. Thank you.
Thank you, sir.
Okay.
Madam, ମୁଁ session close
I'm
କରିଦେବି
leaving
ସବୁ।
for I have to go for a walk now.
Madam, namaskar.
Namaskar.
Sir, namaskar.
Thank you so much. Yeah.
Thank you. Thank
Those
you,
participants who are coming tomorrow, we will see each other. चलो जाइए. Yeah. So thank you very much.
Thank
I
you,
am
sir.
leaving.
Thank you, madam.
Thank you, sir. Sir, namaskar.
Thank you.